Hi everyone, my name is Annie Sevy. I'm the medical director for the spinal cord injury rehab team at Rusk Rehabilitation Hospital and MUPMNR in Columbia, Missouri. I hope you're enjoying the conference so far. Welcome to my lecture on the ASIA exam. To start, just so you don't feel like you're out there listening to a complete stranger, I'll tell you a little bit about me. I'm an assistant professor of clinical physical medicine and rehab at the University of Missouri, Columbia. So I do inpatient and outpatient spinal cord injury rehab there. I'm also a certified level 1 CrossFit trainer and adaptive trainer and a nutrition coach. And I think all that stuff is really cool, but the best part of my life is my family. I have a husband, 2 boys, and 2 dogs, and we like to be active and have a lot of adventures together. And I think that's what translates into my practice. I do my best to help make my patients see what's possible and try to empower them to live healthy, full lives. Before we jump into talking about spinal cord injury, this is what I really want you to know. I think it's important to give out a little encouragement. You can ask my residents. This is something I tell them regularly. And that is that we were all created on purpose for a purpose. I had a friend tell me once that if there's breath in your lungs, then there's purpose for your life. That's a simple but vital truth that all of us need to be reminded of from time to time. We've all been given unique gifts that the world needs. When you figure out where what you have to give fits what the world needs, that's when you found your purpose. That's where you figure out what your why is and find the motivation to help you keep going when challenges come up. You may not be totally sure what that is yet, and that's okay. You might even be in a situation where you're questioning, what is the point? Why am I doing this? I've been there. I'm telling you this, and I'm passionate about it because I've been in a place where I felt I didn't fit at all. I thought maybe I'd made the wrong choice going into medicine. The truth was I just hadn't found the right space for myself yet. Then I was given an opportunity to take over the SCI program at MU and realized that this is where I belonged. Be willing to try new things, keep learning, and keep going. You're meant for great things and here to make a huge impact on others. Remember that. All right, so getting into the lecture, here's what we'll be doing today. We're going to learn a few facts about spinal cord injury demographics and etiology, define the INSCI or ASIA exam and why it's done, learn the steps of the exam, learn how to classify spinal cord injuries. We'll define the zone of partial preservation, and then we'll study a few cases. Start with just a few facts about spinal cord injury. These are things that often come up on boards or on the SAE, for example. In the U.S., spinal cord injury has an incidence of about 11,000 new cases per year. The prevalence is about 250,000 cases. The most common causes of spinal cord injury are motor vehicle accidents, falls, violence, and sports. And the average age at injury is 38, so it's a younger patient population. Okay, so here are a few questions that are really important to know the answer to. Do you know what is the most common level of spinal cord injury? How about what is the highest injury level at which it is possible for someone to live independently? Or what is the highest injury level at which most people can live independently? Don't worry if you don't know the answers yet, because here they are. So, the most common level of spinal cord injury is C5. The highest injury level at which it is possible for someone to live independently is C6. And the highest injury level at which most people can live independently is C7. All right, so you just learned some trivia, but why do we care about these facts about injury levels? This is a lecture about the INSCI exam or the ASIA exam, which is about determining the level of injury. Level of injury plays a huge role in prognosis, which is what your patients care about and what they will ask you about. So, if you know the injury level and you know the science, you can give your patients the evidence-based answers that they need. I think this is something that is unique to PM&R, something extra that we can offer. I've had many patients tell me that I told them more about their injury while doing an H&P than they learned during their entire acute care stay. It means a lot to them and their families, and it sets physiatry apart from a lot of other specialties. All right, so let's get into this. What is the INSCI exam? It is a physical exam unique to the spinal cord injury population, also known as the ASIA exam. It's used to establish sensory, motor, and neurological levels of injury as well as completeness of injury. It's used in research, it's used as a prognostic tool, and it's used to track recovery and monitor for new pathology. Anytime you talk about the ASIA exam, you always end up hearing several different acronyms, and to me it sometimes starts to sound a little bit like alphabet soup. So I wanted to put this slide in here and go through some of the more common acronyms you'll hear when you're talking about the ASIA exam. The first one is INSCI. It stands for International Standards for the Neurological Classification of Spinal Cord Injury. The second one is ASIA, which stands for American Spinal Injury Association. AIS stands for Asia Impairment Scale, and NIL is the neurologic level of injury. So the INSCI exam is a newer name for the ASIA exam. ASIA is the group that created this exam. They're a very research-heavy group that studies spinal cord injury and prognosis and outcomes, classification, pretty much anything related to spinal cord injury they are involved in. So they're the ones who came up with this exam. The Asia Impairment Scale is how you label a spinal cord injury. So like if someone has a C5 Asia B spinal cord injury, you can also say they have a C5 AISB spinal cord injury. And then the neurologic level of injury is ultimately what you're trying to find when you do this ASIA exam. This is a common question I get from my residents. How often do we need to do the ASIA exam? So, according to ASIA, the most accurate exam for prognosis is one done about 72 hours after injury. That can be a challenge to do when someone's still in the ICU, maybe sedated, hooked up to lots of lines and tubes, but if you can do it, you should do it. It should also be done on admission to rehab. So, for example, when I admit a new SCI patient to RUSC, the INSCI or ASIA exam is just part of our H&P. Technically, you're also supposed to do one on discharge from rehab, but I have rarely seen that done. I think it may have to do with the fact that rehab length of stays are getting shorter, so we don't have the time to see as much change as we would need for a better ASIA score. It's also recommended that the exam be done yearly and anytime the patient's clinical status changes. That's the aspect of the exam that allows us to monitor for new pathology. For example, let's say I've got a patient with bony metastasis that caused a T12 Asia C SCI. They've been stable their whole admission. Then one day on rounds, my patient says that their numbness feels worse, and their PT says the patient can't even stand in the parallel bars today, but yesterday they were able to take a few steps with a walker. So what does that mean for me? It means I need to check their sensory and motor levels because they may have new bony metastasis. That's just one example. The same thing goes for something like ruling out a syrinx or hardware failure or infection. All of those potentially could cause a worsening spinal cord injury. So you can use changes in ASIA levels to help determine what the patient needs. We've gone over what the ASIA exam is, why it was created, what it's used for. So now let's talk a little bit about actually performing the exam itself. When you do an ASIA exam, especially when you're first learning it, please take this worksheet with you. You can download it and print it for free right off the ASIA website. I know it looks intimidating and busy, but I promise it makes so much sense if you just break it up into small steps and take one step at a time. So this document is actually a 2-page document. This is the first page with places to record all your sensory and motor scores. This is the second page, which walks you through how to use your motor and sensory testing to determine the ASIA score. Again, I know it looks busy and intimidating and long and tedious, but it is so helpful. And if you just go one step at a time and do it the same way every time, you will get to the right answer. I'll say it again because I know it's a problem. Don't let this exam intimidate you. Break it into small steps. Go through those steps the same way every time. Use your worksheet and you will be successful. All right. I keep talking about breaking this exam into steps. So what are those steps? Remember, the point of this exam is to find sensory, motor, and neurologic levels. So for me, step 1 is to find the sensory level. To do that, you test sensation to pinprick and light touch at specific sensory points. What do you use to test sensation to pinprick and light touch? And how is that sensation scored? To test light touch, a Q-tip with the end frayed out is used. To test pinprick, a safety pin is used. Scoring goes from 0 to 2, with 0 being absent, 1 being altered, and 2 being normal sensation. It's important to know that when testing pinprick, you're testing pain. So if the patient tells you that they can feel something when tested, but they can't discern that the pin is sharp, then they receive a score of 0 at that sensory point. You may be wondering why it matters whether you use a Q-tip versus maybe a soft cloth or a safety pin versus some other sharp object. This is because the exam is highly standardized. Remember, one of the purposes of the exam is for use in research, so it is standardized as much as possible. So to test sensation, you use a Q-tip and a safety pin and test specific sensory points to find the sensory level. Scoring goes from 0 to 2, and all the sensory points you test are compared to what the sensation feels like on the patient's forehead, because their forehead sensation should be normal. This is just a reference back to the ASIA worksheet. You can see that it has boxes to score pinprick and light touch bilaterally from C2 to S5. And the image of the patient has dots added where each sensory point is to be tested. So you can see how having this image can be very helpful when you're trying to test all of these points. So to figure out what the sensory level actually is, you use your Q-tip and safety pin to test all those sensory points. Then you look at your worksheet and you find the lowest level where you have 2s all the way across, because the sensory level is the lowest level where sensation is completely normal. And that's your sensory level, and that's step 1. Step 2 is to find the motor level. There are a few points to know before getting started on that. How should the patient be positioned? What muscles are tested? And how is muscle strength scored? How should the patient be positioned? Remember, standardization is key. So the patient needs to be in bed, supine, and anatomical position. Muscles tested include specific muscle groups from C5 to T1 and L2 to S1. Strength is scored from 0 to 5. When you're actually testing muscle strength, you start by testing to see if the patient has 3 out of 5 strength first. Why is that? Because a 3 out of 5 means the patient has full range of motion against gravity. If the patient does not have full range of motion against gravity, you reposition the muscle and test it with gravity eliminated. If they have full range of motion with gravity eliminated, that gives them a 2 out of 5. If they can't get to full range of motion with gravity eliminated, they get a 1. And if there is no motor function at all, they get a 0. If the patient has full range of motion against gravity, then you can add resistance. If the patient can provide some resistance, they get a 4 out of 5. If the patient can provide full resistance against gravity through the full range of motion, they get 5 out of 5. I realize this is a little hard to see, but this is how the muscle groups appear on the ASIA worksheet. You can see that the C5 myotome is tested using the elbow flexors, C6 is wrist extensors, etc. So everything is labeled for you, and you just fill in the box with the motor score. Once you have all your motor scores filled in, you find the lowest level where they're normal, and that is your motor level. One aspect of this that gets a little tricky is that a motor score of 3 or 4 can be considered normal if all the muscles above that level are 5 out of 5. This is because a 3 out of 5 is considered functional strength. So for example, if C8 is 3 out of 5, but C5, 6, and 7 are all 5 out of 5, then C8 can still be considered normal. Essentially, you're trying to give the patient as much credit as possible to get the best score. After you've found the sensory and motor levels, you can move on to step 3, which is to find the neurologic level of injury. The neurologic level of injury is the lowest level at which sensory and motor function are normal. Here's our favorite worksheet again. I put this here as a reminder that not every sensory level has a corresponding motor level. For example, there are sensory points at T6, but no muscles to test. In those cases, you're supposed to assume that the motor testing would match the sensory testing. So a normal sensory score would give you a presumed normal motor score at that level. Bringing this back to step 3, which is finding the neurologic level, you just look at this sheet, which you will have now filled in with all your sensory and motor scores, and you find the lowest level with normal scores all the way across, and that's your neurologic level of injury. After you've done all the sensory and motor testing, you just have one more part of the exam left, the rectal exam. This is obviously no one's favorite part of the exam, but it is arguably the most important because the results show whether you have a complete or incomplete injury, and that is a game changer for prognosis. To test those last few levels of the cord, S3 to S5, you test sensation to pinprick and light touch just as you do for all the other levels. You then test deep anal pressure bilaterally and voluntary anal contraction. If sensation, motor function, deep anal pressure, and voluntary anal contraction are all scored 0, the injury is complete. If there are any values scored at least 1, the injury is incomplete. Once you find the sensory, motor, and neurologic levels, and you've determined whether the injury is complete or incomplete, then you can move to step 5, which is determining the grade A, B, C, D, or E. An A injury is a complete injury, so no motor or sensory function is preserved in the lowest sacral segments. A B injury is called sensory incomplete, which means there is some sensation preserved in the lowest sacral segments. C is called motor incomplete. This means that there is motor function preserved in the lower sacral segments, but half of the muscles tested 3 levels below the motor level are graded less than 3 out of 5. D is also called motor incomplete and also means that some motor function is preserved in the lowest sacral segments. But for a D, more than half the muscles 3 levels below the motor level are graded at least 3 out of 5. If you have a person who had prior deficits but everything has recovered, that injury would be graded an E. So the scale goes from A to E, with A being a complete injury and E being fully recovered. I realize that was a lot of letters and levels and numbers. This image is from the second page of the ASIA worksheet. It defines each letter grade of the exam, and it walks you through the algorithm of how to figure out what the letter grade is. This is a part of the exam that can be pretty tedious, especially when you're trying to do something like determine whether the injury is maybe a C or D. So I highly recommend referring to this chart as you're scoring the exam. Now, we've gone through 5 steps. We found the sensory level and motor level, which gave us our neurologic level. We determined whether the injury was complete or incomplete. We graded the injury. That's a lot of work, right? But why? Why are we spending all the time and effort to determine this thing called the ASIA score? One reason is for prognosis. So this slide shows prognosis for community ambulation at 1 year. And you can see if someone has a complete injury, or A, they have a 3% chance of community ambulation at 1 year. A B type of injury would have a 50% chance. C goes to 75, and then D has an 80 or 90% chance of community ambulation at 1 year. Your patients will ask about this, and it's important that you can give them accurate answers and hope. You'll notice that nowhere on this list is a 0% chance of ambulation. Even if the injury is complete, that person still has a 3% chance to walk. Someone has to be in the 3%, right? Also, knowing your patient's levels allows you to talk to them and their families about how much help they may need long term. Remember when we talked about patients with C6 and C7 injuries being able to be independent? That little bit of hope can make all the difference in the world for your patient. That is essentially the ASIA exam broken into steps: finding the sensory level, the motor level, and the neurologic level, determining whether the injury is complete or incomplete, and then grading the injury. Those steps will give you your ASIA score. There are a few extra components that we can discuss now: non-key muscle groups, abnormal findings due to a non-SCI condition, and the zone of partial preservation. We have what are known as the non-key muscle groups. You can find this chart on the second page of the ASIA worksheet. Just like in the standard ASIA exam, these are specific muscle groups that test specific myotomes. We use these groups to differentiate between an AIS-B and AIS-C injury. For example, let's say you do your ASIA exam and you find some sensation preserved below the level of injury, but no motor function. That would be classified as an AIS-B injury. However, if you suspect that the patient may have some motor function in a different muscle group, you can double check by testing these non-key muscle groups. If the patient has motor function in these non-key groups, you can upgrade their score to an AIS-C injury. Often, a patient with a new spinal cord injury has other injuries that affect their scores on an ASIA exam, something like a peripheral nerve injury, a fracture, or an amputation, for example. These are conditions that result in abnormal findings on the ASIA exam, but those abnormal findings have nothing to do with the patient's spinal cord injury. Thus, they do not factor into the ASIA score. You simply do your exam, record the abnormal finding with an asterisk, and note in the comment box on the ASIA worksheet why the finding is abnormal and doesn't count toward the ASIA score. The zone of partial preservation is an area below the level of injury where dermatomes and myotomes remain partially innervated. This used to apply only to complete injuries, but since the 2019 revision of this exam, it applies to incomplete injuries as well. The ZPP can encompass a range of levels, and it does correlate with more recovery later after the injury. Just like the neurologic level, the ZPP is named for its lowest level. For example, you can have someone with a C5 AISA spinal cord injury with a ZPP at T6. Prognosis for additional recovery to the T6 level would be better than if that ZPP did not exist for that patient. Okay, so that's the ASIA exam. It's a long, tedious exam, but broken into smaller steps, it's not too bad. The 5 steps we discussed were: Step 1, find the sensory level. Step 2, find the motor level. Step 3, find the neurological level. Step 4, determine completeness. Step 5, determine the grade. Now, let's try putting some of this into practice with a few cases. First case, let's start by finding the sensory level. You can see that C6 is the lowest level at which there are 2s all the way across. So C6 is the sensory level. Next is the motor level. C7 is the lowest level where the patient has functional strength of at least 3 out of 5 all the way across, and everything above that is normal. So the motor level is C7. We have a sensory level of C6 and a motor level of C7. That means the neurologic level of injury is C6. Next, we need to determine whether it's a complete or incomplete injury. You can see that VAC and DAP are listed as no's, and all scores in the S4 and S5 segments are 0. That indicates a complete spinal cord injury. So this patient's AIS score would be C6 AIS-A. All right, let's give this one a try. The sensory level is C4. The motor level is C5. That means that the neurologic level is C4. VAC and DAP are present, and there is some innervation preserved in the S4 to S5 segments. That makes this injury incomplete. There is motor function preserved more than 3 levels below the motor level, so that makes this either an AIS-C or AIS-D injury level. Less than half of the muscles below the neurologic level have 3 out of 5 strength, so that makes this a C. So this patient has a C4 AIS-C spinal cord injury. Here's one more to try. The sensory level is C6. The motor level is C8. That gives us a neurologic level of C6. There is innervation preserved in the lowest sacral segments, so this is an incomplete injury. There is motor function preserved, so we have either a C or D type of injury. Half the muscles tested below C6 have at least 3 out of 5 strength, so this is a D. That means that the AIS score for this patient is C4 AIS-D. And there you have it. We took the ASIA exam and broke it down, and we got through it. Don't worry if something still seems a little confusing. This is an exam that takes a lot of time and practice to really understand. With enough repetition, you will get it, and you will be able to help so many patients in the process. If you have questions, please feel free to reach out. My email is on this slide, and I'm happy to do what I can to help you. Here are my sources for this lecture. Thank you for the opportunity to teach, and thank you for listening. I wish you all the best in your future careers. And again, please feel free to reach out if you'd like to.